Good afternoon, everybody. Thank you so much for coming. My name is Kimberly Gray, and I work with Dr. David Dorr. And he wasn't able to make it today, and so I'm going to introduce his intern for him, who's going to be the first intern presenting today. It's my great honor to introduce you to Richelle McDaniels. Richelle is a sophomore, and she is currently in the Western Oregon University Honors Program. She hails from the Clackamas, Portland area. And currently she's majoring in biology, but when I was talking with her this morning, she said that working with this program has given her aspirations to be a doctor. So we will see where that goes, and looking forward to her presentation.
Hi, thank you, Kim. I don't know, can you guys hear me? Is this on? Okay. All right, so like Kim said, I'm Richelle McDaniel, and I worked with Dr. David Dorr and very closely with Kim on a project this summer. That dealt with measuring patient experience as an indicator of primary care quality through the CAHPS survey. I've literally been referring to it as my capstone project all summer. Glad you thought that was funny. All right, so in a little overview of my presentation, I'm first going to talk about why primary care is important. Then I'll introduce you to PCPCH, CAHPS, TopMed, and our research study. I'll talk to you about my actual role in the project. I'll share with you the results, important findings from those results, and some conclusions that we can make from them. So first of all, why is primary care so important? Why do we have to keep improving it? Primary care is the first step. It's the first point of contact for all patients. In the healthcare system, primary care physicians are responsible for doing preventative care, for managing chronic illnesses. It's essentially what keeps our population healthy. So now that we can move on, so how do we improve it? We are using a model called PCPCH. It stands for Patient-Centered Primary Care Home. It's a model in which, like the name suggests, the patient is at the center of their healthcare team. Healthcare team is held to high standards, to these standards here being comprehensive, continuous, accessible, accountable, coordinated, and patient and family-centered care in order to give the best care possible. And in doing so, this model attempts to improve the triple aim of primary care, which includes the quality of patient care, the overall population health, and cost effectiveness. So how do we measure it? Well, we've used the CAHPS survey. It stands for Consumer Assessment of Healthcare Providers and Systems. And it is actually a patient experience survey rather than a patient satisfaction survey. And they may sound like the same thing, but I'll give you a quick story as to why it's not the same thing. So this guy here, he's in pretty bad shape. So if you asked him, well, are you satisfied with your health and your health care? He probably wouldn't give the highest rating. And you wouldn't know why. You would just know that he gave a low rating. So with patient experience, it measures patient satisfaction in multiple areas, so you have a better idea of where exactly the improvements need to be made instead of blindly trying to improve primary care. And the CAHPS survey measures patient experience in these 11 areas. I'm not going to read all of them off, just know that I'm going to refer to specific ones later on. So now that we have our measuring tool, I'm going to talk to you about our actual research study. So TopMed stands for Transforming Outcomes for Patients Through Medical Home Evaluation and Redesign. It's a cluster randomized trial. And so for the study, we sent out surveys to 800 patients, 100 from each clinic during a pre and a post period. Of each of the 100 patients, 50 were high-risk patients and 50 were low-risk patients. High risk simply means they're more at risk. They have a higher tendency to be hospitalized for various reasons like chronic illnesses or age and other factors. Of the 8 clinics, we had 4 that were control and 4 that were intervention. The main difference between the two is that the intervention clinics were taught to focus on high-value elements after the pre-period and before the post-period. So we'll be measuring to see if focusing on high-value elements really improves the quality of primary care in patient experience's eyes. So before I read off the hypotheses, I want to talk to you about a term that I'll be using a lot, percent positive response scores. And this is simply the percentage of patients that answer the most positively on any given question over all the patients that answer that question altogether. And then each of those percent positive scores are combined and weighted into a total composite score for that particular area of the CAHPS survey that I showed you earlier. There were 11 of them. All right, and then so we had 4 hypotheses for this study, but I'm only going to talk about 2 because that's all I have time for today. And the first one states that the post-study percent positive response scores will be higher than the pre-study percent positive response scores. So in general, scores will go up. Everyone's going to be much happier with their care all across the board. And then the second hypothesis is that the change in intervention scores will be larger than the change in control scores, i.e. the intervention clinic scores will increase more than the control clinics. So now we get to my project and my roles in this. So the first thing we did was finishing the post-data collection. Just to give a quick summary of how we collected the data, we would mail out surveys to 800 patients. If they didn't respond, then we would give them a phone call and see if they would like to still respond or not. And if they still didn't respond to the phone call that I make, then we would send them another survey in order to get the response rate that we want. And I felt like this a lot in the phone calls. All right, and then after we had all of the surveys, I would map the answers that were given to numbers and insert them into the database using the Likert method. I'll give you a quick example. Here's one of the questions from the CAHPS survey. If a patient answered excellent on this question, then I would insert 1 into the database, and that would make it much easier to see the percent positive score. And then afterwards, after all the calculations were done, I would analyze and try to make sense of the data. All right, so before I could look at the CAHPS data and all the composite scores and try to see if there was a difference or if there was a change or anything like that, I looked at the responses, like the number of respondents versus non-respondents, and if there was any sort of bias between, like if they were high risk or low risk, if they were part of the control or intervention, if gender, age, all of those categories. So this can be a little hard to see if there is any biases just based on this graph here. So instead I did chi-square calculations comparing the respondent versus non-respondents in each of these categories, which are high risk, low risk, control intervention, gender, age, and race. And so after doing the chi-square calculation, you will get a p-value. And if it is less than 0.05, which is the convention, then it's considered to be statistically significant. So for control and intervention, gender, and race, there was no bias in whether they would respond or not. So that wasn't something that we have to take into account in the later analysis. But for high risk and low risk and age, there was actually quite a bit of bias. High risk patients tended to respond more than low risk patients, and elderly patients tended to respond more than younger patients. So this is just something that I'll have to keep in mind when looking at the CAHPS answers later, because these will be the people that the opinions we're actually measuring. So, and I also looked at the response rate by taking the number that actually responded and dividing by the expected, and the expected was the total number of people, or the total number of surveys we sent out, taking and minusing the patients that we excluded for various reasons. And for the response rate for the pre-study was 45.55%, and the response rate for the post-study was 42.75, so it's a little bit lower. I'll have to keep that in mind as we move on. So the actual big analysis that we did was a difference in difference to see the differences between the change in control and change in intervention percent positive scores over time. So the best way that I like to explain it is using a series of graphs. So first, I would find the difference between the pre and post scores of control for each of the 11 CAHPS composite areas, and then the same for the intervention. So then we would have our change in control and change in intervention, And then we are going to next find the difference between these two differences, hence difference in difference. And so you take the intervention and you take the change in intervention minus the change in control, and you have the final difference in difference analysis scores. So this is a lot of data. You can see that for some CAHPS areas like 3 and 5, that they increased a lot. So that means the change in intervention scores were quite higher than the change in control. And then for those two negative scores up there, that means the change in control was higher than the change in intervention, which would be the exact opposite of what we predicted would happen. And you might be wondering what all of those little symbols are. They're to indicate whether it's statistically significant or not. So, because it really doesn't mean anything unless we can say it's statistically significant. So, if it has a star, if the CAHPS area has a star on it, then it means it is statistically significant for the difference in difference between control and intervention and pre and post. If it has a heart, it's statistically significant for the difference in difference between high risk and low risk and pre and post. And so the 3 areas where it's statistically significant for the control and intervention are 3, 5, and 6, which is follow-up on test results, patient's rating of provider or doctor, and providers paying attention to your mental or emotional health. And the ones that are statistically significant for high risk and low risk are 5, 6, and 7, which is, again, patients rating a provider or doctor, providers paying attention to your mental or emotional health, and providers support you in taking care of your own health. So this is a lot of information. What exactly can we draw? What's the most important information? So I'm just going to reiterate the important findings that we found with this data. First, we had a lower response rate in the post period than we did in the pre-period. This isn't exactly what we expected to happen. We expected there to be more of a response rate. We also expected there to be a more positive response rate, but instead the scores decreased over time, which meant they were lower the second time around. And the change in intervention clinic scores over time were generally higher than the change in control, which actually does match our second hypothesis. It does support it. And we had some areas that had some very large changes. The ones that are the most notable, 3, 5, and 11, with 3 increasing 16.7%, 5 increasing 13.5%, and access to care decreasing 12.4%. This is probably one of the most surprising results that we've had so far, and we would need an explanation to figure out why. And then the 3 statistically significant differences for the difference in difference, we had, again, areas 3, 5, and 6, and they had less than, with a p-value of less than 0.1. And we had a p-value of less than 0.1 for these instead of less than 0.05 because there's extra variability in trying to measure human opinion, essentially, on these surveys. So why might these have happened? Some people might have said that we just got an angrier group the second time around. But I think that it might be more attributed to one of the recent healthcare reforms. Very recently, we had thousands more patients added on to Medicaid. So that means that primary care providers suddenly have to make room and try to take care of thousands of more patients. So that would significantly decrease your access to care score. Patients that can't get in when they want because they're competing for a spot, essentially, with a lot of other patients. And so why would only that area decrease and nothing else? Like, you would think that they would be more angry at their doctors because they can't get in to see them, but that's actually not the case. When I've talked to patients over the phone, they loved their doctors. They just didn't like the healthcare system. They were frustrated that they couldn't get in, they couldn't get the tests done that they needed to, their backs hurt so they couldn't. It was just a lot of various reasons, but they all loved their doctors. They thought their doctors were wonderful people. So that would be why only certain areas like access to care, which isn't really controlled by the doctors as much as the people in charge of the doctors, like your healthcare, your government, and your healthcare system. And why your patient's rating of a provider or doctor wouldn't decrease. Now, it actually increased significantly, which I actually attribute to the, like we said before, the focusing on high-value elements in the intervention clinics. I think it actually does make them seem like they're really focused on the patient, and it therefore makes the patient feel better about their care, and they will then have better positive scores. All right. One last, I'm going to talk a little bit about specifically high risk and low risk and the findings that we had with them. We found that high-risk patients were more likely to respond than low-risk patients for both the pre- and the post-study, if you remember that far back. We also found that high-risk patients tended to give higher ratings than low-risk patients for both the pre- and the post-study. And we had these statistically significant areas, 5, 6, and 7, in which the response was, unless it was obvious that the high-risk patients were rating more positively than low risk. So why would this happen? What we did not expect at all was that the high-risk patients were responding more than low-risk patients before we did anything during the pre-session. We were expecting there to be a big change with this implementation of the high-value elements in the intervention clinic, because most of the high-value elements are focused on high-risk patients and developing care for high-risk patients more. So why would high-risk patients, which are in bad health, be more happy with their health care before we did anything about it? So I actually developed a theory based on just talking with patients and seeing the little side notes on their surveys when they were mailed in, that I like to call the presumption of health theory. And it's essentially you're presumed to be healthy until you are proven sick, kind of like the judicial system. So it takes a lot of, diagnoses make care easier. High-risk patients have a diagnosis already, so it makes their care very easy for doctors, because when you have a diagnosis, you have a straightforward set of instructions on how to treat them. You know exactly what you have to do. You have to give X medicine and Y amounts for Z amount of time to this patient. It makes it's easier on the doctors to give care to high-risk patients who already have a diagnosis. And in low-risk patients, which tend to be healthy, and so they don't really have a diagnosis of a serious illness or anything, are considered to be just healthy. And if they come in with symptoms of like a cold, it's assumed to be a cold, because they don't have that much time and energy to investigate all of the different symptoms that come in, or of all the different patients that come in to see them. So, and the real problem is when the healthy patients are presumed to be healthy but are actually sick, and so they feel like they have to be their own doctor, they have to really push to get the tests that they need done, they really have to be their own healthcare advocate. And this is a lot of patients have told me that that's what they found the most frustrating over the phone, is that they feel like they have to do their doctor's job sometimes. And so, therefore, your low-risk patients, which are assumed to be healthy, if they are not healthy, then they are going to be less satisfied with their care because they have to do the care themselves almost. Or they have to figure out the diagnosis. And so the sick are better cared for in that case. And that is what I think attributed to the surprising results of high-risk patients already being more likely to respond positively before we did anything. I would really love to be able to test this theory somehow, but I'm not quite sure how I would get started, but that would be like my next steps in continuing this project. All right, so a special thanks to my mentor, Dr. David Dorr. He was wonderful, and I'm really sad he couldn't be here today. Kim Gray, who I've pretty much worked with even more than Dr. Dorr, because this is essentially her project that I took on as her intern. Katrina Ramsey was our statistician, so she did all of the calculations that I would need a PhD in math to do. The rest of the CMP team was wonderful. They are always friendly and willing to answer my questions. And thanks to the top med staff, the rest of DMICE, and my fellow interns, you made it a wonderful summer. So, any questions or comments? Yes?
So could you tell us more about the CAHPS survey instrument itself? Is that a commercial tool, or is it something that you all developed?
Oh, no, it's been used. It was developed by the government. I used to have all this information about when it was developed, exactly when, but it's been used. We used a modified version of it that we picked the questions that we wanted, but this survey's been around for a long time and is used in many different ways, not just this particular research project. Is there anything else about that? Okay. Yes?
Sorry, maybe you said this, but what was the actual compliance rate with the survey? Like how many people, like what percentage of people actually filled it out?
Actually responded? Well, for the pre-study, we had 45.55% actually fill it out and return it. And then the post-study, we had a little bit less, 42.75%. Yes?
Could the CAHPS survey have been improved?
Oh, that's a really good question. I think that the CAHPS survey is kind of, okay, so the CAHPS survey that we used had four answers that you could answer, like excellent, good, pretty good, or like awful. But I think if you had like more choices, like 6, then that might have changed. It might have even improved, given us a more accurate feel of where exactly the patients are feeling it instead of 4 choices, if that makes sense. I also feel like some of the questions could be reworded a little bit, because I did talk, like, sometimes over the phone they would ask me to read the survey, and I'd take the survey over the phone rather than just asking them if they wanted another copy. And I would read it to them very slowly and carefully, and they would still be like, wait, does this mean this or this? So it could be clarified. Different questions could be clarified in different ways also. Okay. That's it. Thank you. Object to that.
Go to my computer. Right click it.
There.
And then project.
Thank you. Thank you. Bye. Thanks for coming.
So a lot of providers hate those surveys, especially in the emergency room, because what they do.
Thanks.
Sort of like the patient satisfaction to some degree, and there's reimbursement.
That's how to take kids.
There's all these different ways that you get paid. Like you get a base salary and then productivity bonuses based on that. So a lot of times your pay may be tied to that. And the truth is, like, you may not have liked me, but I may have done a really good job. Yeah. And sometimes that's more important than you liking me, especially in the emergency room. There's a lot of issues with that. People think actually the use of those surveys is sometimes driven like over basically physicians being too free with pain meds, because you'll get patients who will just cream you on those surveys, and so
you have to be
all right.
kind of nice to them.
Yeah, give them pain meds when
Thank you all for being here. I'm Joan Ash, and this is Lucas Newman. He was my intern for the summer. He hails from Atlanta, Georgia, and the good news for us is that I think that we've convinced him that he really likes Oregon. He graduated from college in June, and so he's available, and we're hoping that he will continue work in this area so that we can continue working with him. So I'll let you take it from there. Lucas actually worked on 2 different projects for me, one a VA project and one a POET project. Our research team is called POET, and so he doesn't know it, but now he's a poeteer.
Thank you, Dr. Ash. All right. And as you said, I'm Lucas Newman. I'm from Atlanta, Georgia. I've worked on a couple projects, and the focus to bring them both in together is delivering qualitative research results through the use of healthcare IT. In these projects, I take qualitative research information and I develop a means to either upgrade through a modification of migrating a site over to a new platform, or I develop a new site or interface for presenting some newfound research information. I'm from Atlanta, Georgia. I have 2 degrees. The first one is Computer Information Systems from Griffin Tech. I have a bachelor's in biology from Gordon State, and I've worked as a pharmacy technician. My background is mostly IT and pharmacy. A couple of landmarks or imagery to kind of represent Atlanta. I thought of the CDC, and then also the Varsity. Varsity is pretty popular for burgers and hot dogs, and it's a pretty cool place to check out. In this presentation, I'll talk about a little bit with qualitative research, and then I'll move into the 2 projects that I focused on for the summer, and then I'll conclude and wrap up. So to get started, kind of to build the groundwork on what is qualitative research, there are 3 major points, and I'll start with the first one. Qualitative research is inductive. The purpose is to generate theory from observation. It is also oriented to discovery and exploration rather than cause and effect. With qualitative research, we're not using a predetermined template or design, and this design can change or evolve over time. It's not a strict framework that you begin with. Qualitative research is also subjective. It emphasizes meanings and how they are interpreted. The researcher tries to understand the perspective of others. We as researchers understand that we are very biased. In qualitative research, it takes an experienced person to be able to get close to the data, analyze that information, and try to reduce the bias as much as possible. Qualitative research is also contextual. It requires a naturalistic approach. With that, it requires researchers to go out into the field to study and collect data. It is also holistic. We are interested in the complete system rather than the parts. And we will also want to ask the why questions and uncover possible causes. Why is the system acting up? What workarounds are we having to deal with? What warning signs do physicians have to omit or kind of go by real quick? And I'll start with kind of move towards my first project that I worked on with my mentor, Dr. Ash. And this is migrating the CPOE.org website. The website, well, to begin, we'll start with a couple of definitions. CPOE is defined as a computer system that allows direct entry of medical orders by the person with the license and privileges to do so. And there are many positives to having an electronic health record system that allows the physician or provider to put information into. Some of these positives include reducing unnecessary variation in care. It also ensures that medications are checked against a database to prevent adverse drug effects. It also prevents illegible handwritten orders, and I'm sure quite a few of you have seen some chicken scratch around and about. As a pharmacy tech, we've had to diagnose, kind of read, and call on a lot of orders that we had received on paper. The POET team, the provider order entry team, is a multidisciplinary team of researchers, and they were led by Dr. Joan Ash. They investigated several sites, and at these sites they wanted to uncover the implications of electronic health record systems. They performed hours upon hours of observations and interviewed system users. Thousands of pages of notes and transcripts were gathered from these observations and interviews. Observations, interviews, and focus groups. Qualitative analysis of data produced detailed information on the factors related to success in CPOE. And now I'll move into the website that I started with. This is a CPOE website that was originally designed and implemented in the year 2000 by POET. And the goal of this website is to produce or provide access to a collection of CPOE resources and links. And these resources include types of unintended consequences, means of getting around or avoiding unintended adverse consequences in electronic health record systems, systems and technical information for rolling out, and then also the recommendations for evaluating or measuring the success of your CPOE rollout. And to do this, to bring it over to the new system or the new platform, originally started with the original site that was developed in 2000, which is a MySQL PHP set, and then I used the Common Spot tools, which is common or used for ohsu.edu, and by taking the information, plugging it in, and moving it over, I'm able to bring it over to ohsu.edu under a similar template, so it looks clean, it's relevant with the rest of the school's website, and also it has long-term update support. As ohsu.edu gets updated, this shares that same template and design, and it's not continued to be on the one that was from 10 years ago. And I'd like to move into the second research project, and this one is VA focused. We were working with the VA on this particular project, and the principal investigators are Dr. Mark Helfand and Dr. Joan Ash. And this is a pilot project. The goal of this one was to create a library of patient narratives related to the social integration of after traumatic brain injury and diabetes diagnosis. Researchers can use the library that we developed to better understand patient priorities and healthcare needs. And on this, to gather information, we used a series of semi-structured interviews. We also, we audio and video recorded those with the permission from the patient. And then we also took these videos and transcripts, and the goal is to put them on a single database that researchers can access. The goal that we're working towards, the model that we're using, is healthtalkonline.org. And what Health Talk Online is it's a site developed by UK Health Experience Research Group, and it's supported by DipX Charity. It's a collection of patient narratives on over 50 illnesses and health conditions, and they're all linked on one online database. As you can see here, they list out the several major sections for different health disorders, and then you can go through and navigate and pick the specific diagnosis or disease, and then you can watch personal videos that are public for anyone to watch. And it's a great resource for clinicians and patients alike. And with this, this is kind of the setup that I was using for developing the mock website. I kind of did a little bit of background research, and I tried to figure out which platform we could potentially use at the VA. And so I developed our web module around what we could use or roll out over there. So I started out with Oracle VirtualBox. I installed Ubuntu server on that. I made a live Drupal installation, added content, developed a template, developed a theme. And then what I did is I went in and saved each page. And then what I could do in Kate, which is an advanced text editor, I was able to load up all the files at once and make changes. And the goal of doing all this work was so that we could have a portable version of our template. We could burn it on a blank CD or throw it on a USB drive. We can mail it over to Britain to show to Health Talk Online. We could share this template and show our ideas. And what this does is, you plug it in, double click on it, and you have what is our modules. The modules, kind of similar to what Health Talk Online uses, is you click on a major category for a disease, and then you kind of hone in, say we want to look at traumatic brain injury, and then under TBI, we have a list of headings, and from those headings, you can pick specific videos. You can watch a specific experience that one patient has and contrast it to another. And it's a really invaluable resource that we're trying to build for researchers to see and then they can adjust healthcare needs accordingly to what the interests of the patients. And over the summer, I learned quite a few things. Coming in, I only had a perception of bioinformatics. With the summer internship, I've had the wonderful opportunity to work with Dr. Ash, and I learned of several other interests in informatics, those in particular being clinical and medical. I had also an opportunity to work with Dr. Hirsch and Dr. McWeeny on a grant application for NIH, and that was a big project, and it took a lot of work, and it was a great experience to learn how that process takes place to get research, to start research. I also learned how to use CommonSpot, which is a content management system, not too unlike Drupal. This particular one has a different back end and different things that make it tick. OHSU website development. I learned the process of rolling out a website on OHSU, and the web help group was very, very helpful. Any issues I had, they helped me right away with those. I also learned about VA website development and deployment. When I developed this template or this mock module for the website, I tried to construct it in the means of how the VA could roll a particular project like this out. I learned about the OHSU Internal Review Board, IRB, and their policies, as also the VA. Two different organizations, two very different structures, and being able to work with both of those kind of allowed me to get an idea of, handling a variety of different projects, but under different organizations. I'd also like to thank Dr. Joan Ash, my mentor. She's been great, helped me out whenever I needed it. It's been awesome to come out here to Oregon to work on these projects. Dr. Mark Helfand, who was unable to make it here today, he's the PI for the VA Personal Narratives Library. Also on that team, Dr. Erica Cottrell, Lauren, and Eric. And I'd like to thank Todd, who helped me set up the new CPOE template on CommonSpot, and DMICE and my fellow interns. Any questions? Yes?
Yes, is the new Poet site live?
It's not live yet. Because I helped out with a couple other different projects, the start date on that got moved back. Within 2 to 3 weeks, the new switch will be flipped and the new site will be up and running. It's just a matter of getting the pages up and then the domain, linking that over. All right, any other questions? Yes?
The videos for the VA site, oh, sorry. Did they have requirements about making them accessible? Like, did you also have to have transcripts or audio only or any sort of requirements like that?
Well, with this project, currently it's isolated to researchers. Now, with the videos themselves, it's video, audio, and transcripts. And the goal is to have all that accessible, depending on the patient's wants. If they want the video published, or for researchers, if they want the video, or just audio, or just a transcript, we would definitely give them that option. And any other questions? Oh, thank you. Oh, no. Oh, sorry. That'd help.
Now it's my pleasure to introduce Kevin Boehnlein. Kevin is the intern who's been working with me this summer. He's from Portland, but goes to Santa Clara University, where he's a rising junior in computer science and engineering. I gave Kevin a really difficult problem because it's a very poorly structured problem, which he'll explain to you. But unstructured problems are sometimes our biggest challenges, both in medicine and informatics. So he's going to tell you about some explorations he did for me this summer to help make some progress and give us some structure. Go ahead, Kevin.
Okay, so as Dr. Gorman said, I kind of dealt with a problem that is, at least at OHSU, there are very few places that do what I was exploring well by any means. And so that's why I came up with the title about challenges of curriculum mapping in medical education. Just a little bit about me. I mean, he said I'm from Portland, Oregon, which is, I think I'm from the Good Sam, and third year computer science and engineering major, which I get a lot of questions about, so I thought I would give a little bit of explanation about what that is. And it's a blend of software and hardware, as you may or may not be able to figure out. And as I was able to find out, they describe it as including introduction and high-level programming. There's some logic design and chip architecture, computer architecture, and a number of different emphases that are not quite theoretical computer science, but not quite hardware, electrical engineering based. It's sort of a nice blend. So the outline, there are a couple of motivating scenarios that I'll outline, and a problem statement which I derived from that, and then the number of approaches that I took to explore how to improve on what OHSU frankly doesn't do very well, which is not a lot, but in this case it doesn't do something very well. And then a couple of takeaways and acknowledgments. So a problem with computers and human language is that computers deal with data and very strict rule sets. I mean, humans deal with data as well, but we deal with communication and expression on a very complicated, convoluted level, which sometimes I think we take for granted. And the answer to when will my computer understand me is a good one, because human language is very complex, and some people might argue beautifully complex, but it's really expressive only for humans. Computers don't really understand structure, human structure, and it's very difficult for them to quantify it and make it something that they're able to process and handle. So machine language is what they would, I would call it their cup of tea. Computers like to deal with zeros and ones and stuff that is structured in such a way that they can process it, and that's not really what human language comes in. I mean, programming languages are a form of making the bridge between computers and humans less obvious, but again, this is not what human language looks like, thankfully, because this is pretty limited in terms of what it can do, at least on the surface. So in comparison, human expression, this is a picture of Shakespeare's plays, or some of his plays, is incredibly, it has a structure, so it's not really proper to call it unstructured, but it has a structure in such a way that a computer can't, by nature, understand how to read the human form of structure and process the words in such a way that, it's able to find a specific word or find a concept or know any of the parts of speech or anything that we apply to human language to make it comprehensible to us. They don't understand any of that by nature. We can give them that ability, but again, that's a difficult problem. So there's two scenarios that we there are a couple others, but two scenarios that we tried to focus on in dealing with curriculum mapping. And the first one is a student, and they may have, for instance, an exam on, I just picked a topic, pain, and they want to study thoroughly, which is hopefully what they want to do. And so by traditional methods, they might have a hard time finding all of the material that they want, at least good quality material. And with data being created at such a high rate these days on an exponential scale, it's just going to get worse. And humans are not nearly as quick and capable of finding things as computers are, but computers also can't understand our language by nature, so we have to solve that problem. And by traditional methods, it would take, this is a rhetorical question, but by traditional methods, it would take an incredibly long time for a human to go through the equivalent amount of material that a computer would be able to go through in seconds. Especially given all the other demands that we have in our lives today. This is kind of a funny picture of what some of us might imagine a late night at the library. And then the other scenario that we dealt with was a faculty professor that perhaps is visiting. Maybe they're fairly new here. And they're teaching in ethics. And they don't really know how the system works. They don't really know the curriculum. And they want to find out where the other students are in terms of their understanding of ethics or whatever branch of ethics that they're teaching in particular. And I guess another rhetorical question you could ask for this situation is how much would they be able to find out without knowing the OHSU sort of environment and being able to access materials that would tell them what they want to know in terms of comprehension by the students that they're going to teach. They don't want to teach the same thing over again. And potential sources, syllabi, slides, readings. I even thought of course evaluations. And as this picture illustrates, in a cartoonish way, it's kind of what we're looking at, and especially with so much data being generated these days. We have to look in so many different places, and it takes so much more time than a computer would. But again, the problem is getting a computer to understand our language and language structure in the first place. So how can curriculum mapping help? Curriculum mapping, in general, from what I could tell, was sort of classified as a tool for more administrative types and people higher up in an educational setting that would use it to identify big gaps or strengths in their curriculum, and not necessarily for the two examples that I just gave, where you have like a student or a professor and they want to find out where something is in the curriculum and they want to use it either to study or to figure out where their community that they're going to be speaking to is at in terms of understanding. It's not necessarily made for that. So an idea as an end concept would be to make an interface that would cater to the administrative types, but also be able to benefit people wanting to do an average, say, Google search of the material, which, again, is a very complicated problem. So, as I mentioned, curriculum mapping is a very difficult task. Schools do it on a certain level, but usually on a very topical level, just indexing the course names, the slide titles, and that kind of thing, which is not very rich in terms of what it's accessing. There's a lot of stuff that's hidden in a slide, in the slides, or in a reading that may not be obvious from the surface title. And so the question is how we can leverage natural language processing, or NLP, techniques to make the curriculum material quickly and comprehensively searchable. So I took a number of approaches when evaluating what options OHSU might have for developing an end application for use in the school. I first took only one of many sheets of Excel objectives from the old medical school curriculum. And after receiving the output, plugging into these different programs and receiving the output, I took the input and either adjusted the input text itself or the parameters to make the output more desirable to what we were looking for, make it more readable. Some of these programs don't make their output very readable. And then I pretty quickly generated opinions about how this may or may not be useful for OHSU's needs. And this is an example of a lab, the objectives defined by one of the labs for the GIE section of the curriculum. And this is clearly human plain text, but again, it's just displayed in an Excel document, and the computer doesn't necessarily know how to deal with this, deal with the structure, and deal with the typos and irregularities of human language that we take for granted, but the computer doesn't really know how to deal with. The first sort of group of programs I dealt with were standalone programs. They're generally very sparse. These are just a few examples of the kind of programs that are out there. The main one I dealt with was Mallet, and these programs deal with the command prompt a lot, which is not very user-friendly. I actually had some trouble trying to understand the documentation. They're not very nice to look at, not really what we're looking for in the end, but even though I ran into difficulty with them, they could be useful for someone with more knowledge. I'm not very experienced in these tools to begin with, so they would be used for something like a mashup and bringing different resources together to make an application, not just be able to do it all by themselves. They're not specific either to medical text. They're just general programs. Second group of programs I dealt with were from the National Library of Medicine's Unified Medical Language System, which includes a metathesaurus of medical vocabularies, a semantic network to link things together, and then a number of tools to help you do some natural language processing. And this is a very nice, free, actually, tool for, at least for U.S. citizens. You have to get a license to use their tools, but it's free, and I got my license right away, which was nice, and you can use it however you like. My initial approach was to use MetaMap, which is, again, another command prompt-based program which is hosted locally on your machine. But I ran, again, into problems with the command prompt. I got errors that I couldn't quite figure out. So thankfully, I stumbled upon these batch tools that they've made and posted online and allow you to use their own servers and systems to use MetaMap, which recognizes UMLS concepts, SEMREP, which recognizes subject relation object triples, and MTI, which summarizes text into mesh terms. I mostly dealt with MetaMap, which is what I originally tried, but this was in a different form with an easier-to-use interface, so it was more user-friendly. And the other two I used, but their output was much more difficult to understand and not as clear as MetaMap, although MetaMap had its own problems. And as I say down below, MetaMap, while it had a nice interface along with the other ones, it had quite a few unexplained options that could have helped us refine the output and make it more we wanted, but were unexplained, and to someone that's uninitiated, which would be me or anyone else that is not an expert or has used this program a lot, would have a hard time understanding in terms of what would benefit them. And then SEMREP and MTI, while they provided fewer options, their output was less obviously readable. And it may be more useful to someone that can study the documentation and really understand it, but it was less obviously useful than the MetaMap's output. This is an example of the output that I got from only a small part of the lab objectives that I posted a few slides ago. This part, and it's doing a processing of these 5 words right here. And one of the main problems with MetaMap is that it generates a huge amount of output. So again, even though there are a lot of options, I couldn't really figure out how to sort of bring things down and make it more easily readable. And it's, for instance, at the top, it's taking the 5 words, cutting out some of the unnecessary bits, and then generating UMLS concepts and linking them with their unique IDs. And it doesn't always work very nicely. It would prefer that the input text be in a certain manner to make things better, but this is just an example of the kind of output I got, probably one of the better examples. This is an example of all the options I had when using MetaMap. Only the ones that have the question marks and the blue circles were explained at all. Again, I'm new to this material, so while I could figure out some just by what they used to describe them, there wasn't further documentation to see like how other ones may affect it. And while I was able to do some paring down, again, there's a lot of stuff that I didn't quite understand, which even though I had a contact at the National Library of Medicine, even he couldn't help me 100%. So, just an example. Knowledge map was the third sort of approach that I took, and it's a program that Vanderbilt developed in the early 2000s. At least it's the period that I think they developed it. It's kind of hard to tell based on the documentation. And it's a course management and indexing service that they developed for the medical school, which sounded pretty much like what OHSU wanted, or what we want. And so I looked into it. Thankfully, they were nice enough to give us access. And even though they're phasing it out and moving to a new system called VStar, which is much nicer, it still seemed to fulfill a purpose. And this Condial is just an example of one of the searches that I did, and how it marks the text to show you its hits is this little blue arrow, which is not very obvious, but on the previous screen it'll show you all the documents that have hits for whatever term is that you search for, and then it'll mark them if you click on the document with the blue arrow, which is pointed out. And my impression is that it's closer to what we want, and it makes things more readable. It displays the documents the way you would view them in a word processor. But it's also like not, at least this particular version, I don't know about VStar, which is more full-featured. This knowledge map is being phased out, so I don't know if it's quite what we're looking for, if we'd even be able to use VStar, which is a more comprehensive learning management system, which also has this functionality, but is what they're focusing more of their resources on. So I don't know if this would be exactly what we're looking for, although it is much more polished and promising than either of the other two approaches, which would require more development and implementation costs versus this, which we likely would have to pay for, which is not unexpected, but if this ended up being what we wanted to go with, it would save us development and development costs in terms of having to make our own application and interface versus something that's already been developed. And Vanderbilt's a hotbed for this kind of thing, so they know what they're doing. A few of the takeaways: OHSU is not very good at this whole curriculum mapping thing. They do some limited mapping of like slide titles and some very topical stuff, but not the real like meaty sections of getting into the slides, looking at readings, stuff that may be obscured by just looking at the title. Because as has been used a number of times, there isn't necessarily a class about the stethoscope, but it's everywhere. If you wanted to learn about it, you wouldn't necessarily be able to find it just by what they're doing already. So there's two approaches that OHSU could do. They could build a mashup, which would take more development and resource. There would be more costs involved with that, and it would be time-consuming, whether it was done here by a third party, or they could, if it's even possible, we have not completely explored the avenue of getting an outside program to help us with this content indexing service. And while we do have Elios, which is the learning management system, there is not a whole lot of this content or concept mapping, curriculum mapping, being able to dig into the content. So where if a student wanted to look for a given subject, they'd be able to find it in this slideshow, that reading, this syllabus, whatever it is they want to, and it's not necessarily covered by the topical, just the title of a slide or something like that, the notes or whatever it is. This is curriculum mapping. The idea is to make things much more richly available and to allow people to use it to do, I guess, my concept of the final product would be sort of like something that is a Google-like interface where they'd be able to ask questions of the content and be able to get their answers and be able to tell specifically where it is, like which slide it's on, and be able to tell more than just the title would give them. Final thing is, if either of these approaches is what we're going with, then it's going to take resources of a certain kind, time, more time for the mashup, also development costs for that. But if we go with third party or the outside institution's work, then there's also going to be costs with that in terms of, I'm sure, licensing and all of that, which is not my department. But acknowledgments, OHSU, for having all of us. Dr. Paul Gorman, my mentor. Dr. Melissa Handel, who helped us early on and gave us impetus to look into MetaMap, which she knew more about. Nathan Baer, who was our contact at the NLM, who helped us out a little bit. And then Dr. Joshua Denny, Dr. Anderson Picard, and Peter Speltz, who were our sort of contacts at Vanderbilt to help us out with Knowledge Map and the problems that we actually ran into with that. And then also my fellow interns. That's it. Any questions?
No, the hour is late. One question I think we have time for.
What course materials were you looking at for the management system when you're trying to determine course materials?
Well, right now we weren't dealing with what the examples of stuff that would be useful for people, like slides and notes and readings and that. We were dealing with I dealt with one sheet of an Excel document that contained objectives, listed objectives for the labs and courses within a certain part of the curriculum. That's what we dealt with for this test. The idea is to expand that, obviously, to slides and readings and all the other course material that's out there and is only going to grow and making it more accessible by computer.
Okay, thanks everyone.